Hi, everyone. Welcome back. Today, we're joined again by Dr. Eddie Stenehjem to give our weekly COVID-19 update for the state of Utah. As always, we're going to start with the case trends and go over what's happened in the last week since we've spoken. Our total case counts for the state of Utah are 271,940. Today's daily case counts was reported at 2,614, which brings our 7-day rolling average positive rate to 25%. We've had a total of 1,256 deaths in the state of Utah, with 21 reported today. Our hospitalizations are at 10,873, with 484 reported today. And our vaccines, which we've added since the last 2 weeks, are at 23,970 for the state. And I do know there's a slight delay in what's reported on that number from what's happening currently. So, Eddie, let's break that down a little bit. How is our 7-day positive rate going compared to it has been in the past?
Yeah, I mean, we're definitely seeing this pretty high test positivity rate. I mean, today's reported test positivity was 28%, which is the 7-day average of 25%. That's really high. And we certainly had some high days of 27%, right before Christmas. And so that's concerning. The test positivity rate is a reflection of a couple things. One is test seeking behavior. So if we have more and more people seeking tests, the denominator gets big, your test positivity comes down. That has to do with test availability, what our state is doing in terms of mass testing. And then it has a lot to do with community transmission as well. So if you're having lots of community transmission with not a lot of test seeking behavior, you've got this high rate. And so it is something good for us to follow and to trend, with those caveats that as testing seeking behavior changes, so will our test positivity rate. And as our testing availability changes, I'm thinking ahead to after January 1st, when we're going to be doing more testing in schools, those types of things, that's going to lower the test positivity rate because we're going to have more tests in the system. But as it stands right now, real high rate. I think it's just really indicating the fact that not enough people are getting tested and that we have very significant community transmission still, even though our numbers look better.
And as far as our ICUs are doing, I didn't have a chance to pull that referral number, but how are our hospitals doing comparatively to in the past?
Yeah, so following hospitalizations, like we've talked about many times before, is a great marker to follow in terms of what is happening in the community, because as opposed to, daily testing numbers, which is really indicative and reflective of your test pattern, your testing pattern, hospitalizations really, don't have any impact on that, because if patients are hospitalized, they need to get hospitalized regardless if it's Christmas Day, New Year's Day, or a random Tuesday. And what we've seen with our hospitalizations is that they've come down. They had a nice dip kind of right before Christmas, and we're now kind of a pretty plateaued, kind of high level of occupancy. But for the first time in weeks, we now are below that 85% capacity threshold, which is amazing. That has given our healthcare workers a little time to kind of catch their breath. That being said, that's still a huge number of patients in the ICU being treated for COVID-19 and resulting in significant mortality. And as you've seen in the recent days, we've had pretty high fatalities reported as well, which is just indicative of our, pretty significant ICU population as well. So things are better, cases are better, hospitalizations are better. Now we're all just kind of pins and needles to see what happens after the Christmas, Hanukkah, New Year's holidays in terms of case counts, and then subsequently with hospitalizations.
And as far as the holidays go, if a spike does happen, when can we expect to start seeing those cases increase?
Yeah, so I mean, I'm doing COVID rounds for Intermountain Medical Center this week. And we've already reviewed a couple cases that were just admitted in the past day or two that are likely linked to holiday gatherings. Traditionally, what you'll see is that you'll start seeing positive cases around 5 to 7 days after the event. Think about the transmission of the virus, and you think about the incubation period, then you think about a couple of days to seek care, and then the test needs to get reported. So you're really going to start seeing increase in cases, starting probably 5 to 7 days after holiday events. So if you start thinking the 24th was Christmas Eve, add 5 days to that, the 29th, 30th, this would really be starting that window of when we might start to see increases in cases. But that window is going to be pretty long because you have to account for New Year's Eve as well. And so we're coming into New Year's Eve tomorrow, New Year's Day, another time for gatherings. And so that window of when we would expect to see the cases come from this holiday season is probably out till mid-January, given the fact that, January 1st is a big holiday, plus, at least 14 days after that to really see the true impact. So we really have to be watching carefully here for the next 14 days, or pardon me, until like mid-January.
I know you mentioned tomorrow is New Year's Eve. It's generally a day we gather with friends or family. I know we've talked about recommendations for holidays in the past, but what are your recommendations for this weekend as far as what we've been seeing and what people should be doing now?
Yeah, I mean, our recommendations haven't changed at all. This holiday season, our recommendation is to only gather with people in your home. Don't invite others in that potentially could have the virus, either symptomatically or asymptomatically, that could potentially transmit the virus. This is what we recommended at Thanksgiving as well, consistent with CDC recommendations. Our community transmission rate is just so high. I mean, 28% positivity, 25% rolling 7-day average. There's just a lot of COVID-19 still in our communities. And if we are gathering in large groups, we will be transmitting that virus, even at the current numbers.
Someone asked us a question around rehospitalizations and whether you're seeing any of that with patients who have long-term effects of COVID-19, who maybe came in originally or maybe never did, and now they're presenting to the hospitals with these other effects from the virus itself.
We definitely see readmissions. There's a bunch of different patterns we see with this. One pattern is somebody comes in with the acute onset of COVID-19, they require oxygen. They're not terribly sick. They're admitted to the medical unit. They get oxygen. They stabilize. They're not getting worse, and then they get sent home. They get sent home with good follow-up, primary care, or remote patient monitoring. And then at home, they eventually then decompensate and then get readmitted to the hospital. Within COVID-19 and COVID-19 pneumonia, you really have two phases. You've got this acute viral replication phase causing high fevers and shortness of breath. But then what comes next is this inflammatory phase. And this inflammatory phase can also be associated with worsening oxygen saturations, requiring high levels of oxygen, ICU care. And so that second inflammatory phase can definitely occur and cause people to be readmitted. Then we also see people being either readmitted or admitted kind of late in their disease course with complications from COVID-19. We just saw a case on rounds of somebody who had COVID in early December, got over it, then presented with acute shortness of breath and had a blood clot in his lungs, likely related to COVID-19 in this hypercoagulable state. We've seen other people come in with this multi-system inflammatory syndrome in adults, which is similar to what they see in kids. That usually occurs late in the course and comes in with shock and multi-organ failure. And so we absolutely see either readmissions or late admissions for the complications of COVID.
I want to switch to the UK strand. I know we touched on this last week, and Dr. Todd Vento touched on this a little bit on Monday. But since then, it has come out that we found the UK strain in Colorado. What does this mean to us as consumers? And are there any concerns about treatment plans or the vaccine for this specific strain?
Yeah, so the UK variant, the B.1.1.7 variant, which lots of active study ongoing right now in terms of what is the clinical effect of this variant? Is it more transmissible? Does it cause more severe disease? Does it alter our diagnostics? Does it affect the vaccine efficacy? All those studies are currently ongoing. It does look like from the data in UK that it may very well be more transmissible and that it may bind more efficiently to human cells, which makes it essentially more contagious. That work is ongoing. Keep in mind that the public health practices in the UK is different than in the US. And we are seeing spikes all over the world, even though that they don't see the variant. So we're trying to sort out what is the true impact of this variant. We don't know definitively right now, but early data suggests it may be more transmissible and that it doesn't impact severity of disease, and it doesn't appear to have an effect in terms of vaccine efficacy. So it was reported yesterday that, yeah, for the first time here in the US, there was somebody identified in Colorado that had this UK variant. It should be noted that the person that has this UK variant that had been identified is somebody that was in pretty rural Colorado, kind of eastern side of Denver, where it gets pretty rural into the plains. And that person hadn't traveled. So that person hadn't been to the UK. They hadn't been to South Africa. There was a native Coloradan. And so that tells you a couple of things. One is that this person didn't bring this virus in to the country with him, that he got this virus from somebody else in Colorado. And so just that alone allows us to understand that, yeah, this variant is here. It's just that we haven't identified it yet, because across the US, we don't do a lot of viral genetic sequencing like they do in the UK. And so I suspect that we're going to start seeing more and more reports of this UK variant being found in the US. The impact of us in the US is kind of yet to be determined. We're all in different phases on phases, waves on waves of this pandemic. And we just need to keep in mind that our public health messages of social distancing, masking, hand hygiene, limit your contacts, that works for the UK variant or the variant that we have in the US. And so it's really, doubling down on those public health measures while this vaccine is being rolled out. And it really is kind of a race against potentially a new transmissible variant and our vaccine distribution.
Question on that too. So you said the strain is more contagious, but the actual severity of the virus isn't. Have we seen any correlation to an increase in death rate in the UK? Because in my brain, if it's more contagious, it could potentially get to someone who's high risk easier, therefore hospitalizations, potentially death. Is that something that's been studied at all?
Yeah, so we have to separate those a little bit, that you may see more cases due to the variant. But what you're looking at is the death per cases identified. You'll see more deaths because you're going to see more cases. But what you want to know is the percentage of cases that get infected leading to more deaths. And so far, that hasn't been seen in the UK. And it does not look like this variant is more, causes more severe disease. It also, the vaccine manufacturers are saying that it looks like the vaccine that we currently are deploying here in the US and in the UK appear to be equally as effective against this variant versus the wild type.
That's good to hear. Before we switch to vaccines, I have one other question for you. We got this question last week and didn't have a chance to answer it yet. But a viewer asked or said to me, our family had COVID in October and her child was then exposed to someone the other day and started showing symptoms of a cold. Are they potentially exposed to COVID again, and do they need to re-quarantine? What are your thoughts on that?
Yeah, so I would say if that person is symptomatic, then they absolutely need to go get tested. And so if they were, they had COVID in October, now have been exposed to somebody with active COVID, and now that person is exhibiting symptoms that could be consistent with COVID-19, cough, runny nose, sore throat, fevers, chills, any of those, then absolutely that person needs to get retested, 100%. Active symptoms should warrant testing. And keep in mind that we're really not seeing a lot of other viruses circulating in Utah. COVID-19 is by far and away the most prominent respiratory viral infection that we're seeing here in Utah. And so if you are having any of those symptoms, regardless if you've recently had COVID, even as recent as October, that you get retested. Now, in that individual, if they truly had COVID in October, the data right now would suggest that they are relatively well protected for a number of months in terms of reinfection. So I think that likelihood of that person having COVID-19 again is low. But that being said, they absolutely need to get retested if they have been exposed. And then absolutely, if that test is negative and it was a high risk exposure, then yeah, you're going to have to go ahead and quarantine again.
You brought up other viruses, and so I'm going to ask this question really quick. Yesterday, it was reported that there's only been 5 cases of the flu in Salt Lake County. Why do you think the numbers are so low? And then another question, if masking is potentially preventing the flu, why do we still see COVID cases going up?
Yeah. So absolutely spot on, consistent with our data within Intermountain in terms of seeing essentially no flu across the state of Utah. Within our data, so we have 24 hospitals, over 200 clinics. We monitor our influenza activity on a weekly basis. And I can tell you about this time last year, we were seeing well over 80 to 100 cases of influenza per day. As of right now, within the Intermountain system, we've seen 3 cases, in all of, in the past, 3 months. And so those cases were flu B. We have not seen any significant activity of influenza across our sites. And it should be mentioned is that we're looking for it. And so when we look at, well, how many flu tests have we done? We've done plenty of flu tests to be able to identify if it's been circulated in the state of Utah. So it's not from lack of looking, it's just that we're not seeing influenza. Now, why that reason is, I think is a couple things. One is that I'm hoping that we had increased vaccination rates. I don't have those numbers from the state, but there certainly was a push, within Intermountain and across all healthcare organizations and the Utah Department of Health to get people vaccinated. Okay, so that is hugely helpful, one. 2 is that these public health measures that we're doing works for influenza. And then 3 is that typically we get influenza brought in from the Southern Hemisphere in time for our winter season. And the Southern Hemisphere had an incredibly attenuated or low flu season as well. And so you had low flu coming in to the US, you've got everybody wearing masks, you've got social distancing, and you had high rates of vaccination. We really hope that that kind of lets us ride out the flu season without seeing any significant activity of influenza. Now, we've said, well, these measures protect us from COVID and COVID transmission as well as flu. So why are we seeing COVID? So a couple of reasons. One is that it's more contagious than influenza. And 2 is that it was already in our communities before we came into the winter months. It was circulating at high levels, so it's already in our communities, and we don't have a vaccinated population. And so increased contagiousness, having this virus in our community, throughout the summer into the fall at very high rates, and then a non-vaccinated population, that's why you're seeing COVID and not seeing influenza.
I want to switch gears to the vaccine. I have a lot of questions for you, and we've gotten quite a few on the Facebook Live. But the first thing I want to talk about is mRNA. This vaccine is an mRNA vaccine, and I want to talk about the safety of this vaccine. Is this the first mRNA vaccine that's been released to the market? That's my first question for you.
Yeah, this is the first mRNA vaccine that has been FDA approved and widely distributed in the US or in the global population. mRNA vaccines have been studied for, at least for the past 5 to 7 years in a number of different viruses, Zika virus being the one that comes to mind. And those pandemics didn't go far enough, and didn't allow for, mass distribution, because typically those pandemics, resolve before they could actually get to a phase 3 trial. And so data has been present on mRNA vaccines going back to 2015, 2016, but it hasn't come to market. So this is our first vaccine using mRNA technology to hit market.
So if that's the case, and I'm asking you these questions because I've seen them before, how do we know that an mRNA vaccine is actually safe for us?
Yeah, sorry, I kind of forgot that last part.
You're good.
So we know from the previous vaccine trials in Zika and some other viral infections that all of those trials appear to be safe. They never got to big phase 3 trials though. And so we didn't have mass administration on the orders of tens of thousands of people receiving active vaccine to be able to make a determination. The reason we know they're safe is that now phase 3 trials have been initiated and completed and gotten to their first interim results. And if you look at Pfizer and you look at Moderna, over 15,000 people in each vaccine group or in each trial, received active vaccine. So we have well over 30,000 people that has received an mRNA vaccine that have at least 2 months of follow-up. And so that's a lot of people to be able to detect any kind of safety signal. And what we also know about vaccine safety is that the majority, and you push some of the vaccine experts, like they would say all of the serious safety effects from, or adverse events from a vaccine occurs within the first 2 months. And so Guillain-Barre and allergic reactions, those things occur early. And that's the reason why we needed at least 2 months of safety data to be able to go to the FDA for an EUA, or emergency use authorization. And so we haven't seen any of those safety signals in our FDA trials or in previous vaccine trials. And that's why we know that this is a safe vaccine to be able to be administered on the orders of millions of people across the US.
So now that people are getting vaccinated, we've had a few questions about what kind of happens afterwards. Are people required to quarantine after they get their vaccine, or what's the process like for that?
Yeah, so after a vaccine, whether it be this vaccine or other vaccines, you can have side effects from the vaccine, which are normal and expected. And that's your immune system really kicking in, recognizing what is a foreign protein and developing an immune response to that. That is incredibly common and to be expected. So the most common is arm soreness. You also can get low-grade fevers, chills, fatigue, muscle aches. All of that is incredibly common. In the mRNA vaccines, that's much more common after the second dose than on the first dose. So after the first dose, for me, I had some arm soreness, but I really didn't have any systemic symptoms at all. I just, had this arm soreness. My wife, she's a doc at the VA, got vaccinated on Monday. She had a very similar kind of profile of symptoms where she just had some arm soreness for about 48 hours. Now, in people that do have systemic signs and symptoms of fevers, chills, myalgias, things like that, those can be COVID-related, symptoms. And so we've set up a process within Intermountain to really evaluate those. And so if that person gets the vaccine and then is scheduled to work the next day and they have symptoms, and they can't take the day off, then they go in and they get a rapid test for COVID-19. If that person has symptoms but are more consistent with COVID-19 than in terms of post-vaccine related side effects, so if they come and they have cough, if they have sore throat, if they have runny nose, those aren't symptoms of the vaccine. Those are more symptoms of an upper respiratory infection, which now would be COVID-19. Those people need to self-isolate and get a standard, PCR-based test for COVID-19 and not come to work. And so we've set into place a number of processes to evaluate people that have symptoms if they have to come to work, to make sure that people aren't coming to work with active COVID and we're keeping our patients safe. We're also trying to do our best to make sure that people that are on active shifts, so people that are maybe in the ICU for 5 or 7 days in a row, that they're getting vaccinated at the end of their clinical shift, meaning the end of that 5 or 7 day period. And so then if they do have symptoms, they don't have to come to work the next day. So lots and lots have gone into this process of making sure that our caregivers and our patients are safe in terms of these side effects from the vaccine.
Someone just asked if you got Guillain-Barre, which I'm not sure if I'm pronouncing that correctly, but from the flu shot and can no longer get the flu shot, should they stay away from this specific vaccine?
Yeah, so Guillain-Barre is
Butchered that.
That's all right. Amanda, you don't need to know that. Guillain-Barre is what they're referring to. It's an ascending paralysis that has been associated with vaccines in the past. The Guillain-Barre Association, there is one, has come out in support of this vaccine. There has not been any evidence of Guillain-Barre after vaccination with this mRNA vaccine. And so they do have the support of the Guillain-Barre Association, and other neurological societies have, also agreed. And so at this point, if you have had a history of Guillain-Barre associated with a vaccine, what I'd say is talk to your physician. Talk to the physician about whether or not this vaccine is right for you. Go and make an appointment and discuss that with your physician. we would counsel that person based on their risk profile, based on what happened with their original vaccination, whether or not that vaccine is right for you. If you had Guillain-Barre associated with something else, many times Guillain-Barre can be associated with gastrointestinal infections. By all means, absolutely get the vaccine. So in true cases of Guillain-Barre associated with the vaccine, I'd say go talk to your physician prior to getting the vaccine. And you've got time now because, most of this, will be affecting the general population. And you've got time to go talk to your physician before vaccine is available on mass scales.
Someone also asked us a question about concerns over the number of healthcare workers who have opted out, which I'm not sure how many that actually is. But as a doctor who got the shot early, what counsel do you have to offer to those people and caregivers who are choosing not to get the vaccine or that kind of need some more, not convincing, but information or research in order to get it?
Yeah, I mean, so of the healthcare workers I've talked to, the overwhelming majority have been enthusiastic of this vaccine and have gone and gotten their vaccine. I was giving vaccines yesterday in our vaccine clinic, and it's a celebratory type of environment. People are so excited to have another layer of protection that they show up in droves. And so for those people that are on the fence, I would say, look at the science, look at the data, go read those articles yourself, look at trusted sources, the ACIP, CDC, in terms of what they're recommending from the vaccine, and do your own research. Don't go to social media to try to get information specifically about the vaccine. I realize this is on social media, so I get the irony in that. But if you're really interested, go to the primary literature, read the studies, understand it for yourself, and then go talk to your physician or advanced practice provider to get more information.
Sorry, I couldn't get off mute there for a second. So another question that people have been asking us a lot about is this concept of herd immunity with the vaccine specifically. I want to first have you answer, what does herd immunity mean in terms of a vaccine?
Yeah, so we'll start there. Herd immunity essentially means you have a population that is not susceptible to an infection, in this case, a virus. And so if the virus comes into your community, that it can't spread. It can't find enough susceptible hosts to maintain transmission. And so if that virus comes in the community, it essentially fizzles out with one or two people getting infected and nobody else, because everybody around that index person is vaccinated or has some level of immunity and can't get reinfected. Okay, so that level typically is around 70 to 80%. It's a moving target. I don't have an exact number, but that's in general about where herd immunity is. And that's at the level where you stop community transmission altogether of a virus, in this case, COVID or SARS-CoV-2.
So if we're going to get to that, what's a timeline that's actually potentially feasible to get to something like that?
I would argue that we don't know if herd immunity is feasible. And so to herd immunity, you have to have that high level of a non-susceptible population. And so that would mean that you get the vaccine, your 2 doses, and that you are no longer susceptible to this infection. We have no idea how long immunity is going to last after this vaccine. We don't know if it's going to last 6 months, a year, 2 years, or a decade. And so hypothetically, if your immunity only lasts a year, then in order for us to maintain herd immunity, that would mean that 70 to 80% of the population would have to be vaccinated annually to maintain that level of immunity in our communities, in our population, which then wouldn't prevent the virus. It would prevent the virus from spreading. And so we really, it's hard to say anything about herd immunity because we don't know how long this immunity is going to last. But let's just go with the notion that this immunity is going to last for years, for example. In order for us to get to that, we have to get 70 to 80% of our population vaccinated. And based on Operation Warp Speed and the predictions that they're making in terms of vaccine manufacturing, and the fact that we likely will have at least another couple vaccines coming on the market, which will help with our supply, it's feasible that we could get to herd immunity as long as people get the vaccine by the fall, fall to winter. That's really kind of, I think a reasonable target to get there. But, in order to get there, you have to have 70 to 80% of the population willing to get vaccinated. And I think we're moving in that direction. The numbers that Angela Dunn reported a week or so ago is that over 70% of Utahns are willing to get the vaccine, which is up from 50%. So just based on those surveys, we're on our way. But so that's what you're talking about, herd immunity. I think that's off until the fall and winter. But I would argue that our first priority is not herd immunity. Our first priority is maintaining the health and the integrity of our healthcare networks. And so that our hospitals aren't so full of patients with COVID-19 that when you or your loved one needs care for whatever reason, COVID or heart attack or stroke or trauma, is that we're there for you, is that we have a bed and we have a healthcare provider who is the best person that's trained to care for you, whether it be a nurse, a respiratory tech, a physician, whatever it might be, that they're ready and they're well rested. That's our initial goal. Our initial goal is to really make sure that our healthcare systems are safe and healthy. And for that, we really have to get out and vaccinate those high-risk people that are most likely to get hospitalized. And so what you're going to see is as we start vaccinating the long-term care facility residents, as we start vaccinating those above age 75, as we start vaccinating those that are 65 and above and those that have comorbid conditions, that's the population that leads after infection, that leads to hospitalizations that fill up our hospitals. So our first goal is to vaccinate those people so that takes that stress off our hospitals. And so we're there for all of our community members. Then the next goal is herd immunity. And so I think our focus shouldn't be herd immunity right now. Our focus should be, how do we get to those high risk people that are most likely to have a severe outcome and possibly die?
There's been a couple of reports nationally about talking about the rollout of the vaccine specifically. And there's been people speculating that it could take 5 to 7 years for people to get vaccinated at the rate that we're currently going. Do you think that there's anything we can do as a healthcare system or even a state to speed up the vaccinations to the general public potentially?
Right. I mean, part of that discussion, and we don't have to go into detail in this, is that there wasn't any state funding from the federal government in terms of vaccine rollout. And there really wasn't any assistance from the federal government in terms of the plan for vaccine rollout. That was just put on all the different states. Now with the stimulus package coming, there is funding in there from us for individual states to put money towards vaccine rollout. It was slow initially. I mean, keep in mind that, just Intermountain Healthcare has 40,000 healthcare workers, and we need to use our healthcare workers to vaccinate those 40,000 caregivers. And so we are pulling healthcare workers from other clinics, other places to act as vaccinators. That's why yesterday I went and vaccinated, our population Intermountain Medical Center. And so I was vaccinating along with somebody who was coming from the newborn ICU, an urgent care doc, employee health nurse. And so we are pulling those people to ensure that our healthcare force is getting vaccinated. And now we are up to speed and we're moving quickly. Over 3,000 people today are likely to be vaccinated within Intermountain. 1,900 were vaccinated yesterday. And so we are really hitting our stride. And then I think it really is, we're going to be, really looking to the Utah Department of Health of how is this going to work once we open this up to people that are above age 75, and then after that, above 65, or those with comorbid condition. And we'll be looking to them in terms of, how do you want us to do this? And that's going to be a collaborative partnership that will evolve. But I suspect that, Utah will rise to the challenge in terms of being able to do this efficiently.
You read my mind. That was the next question around what do we do now when the 75 and older population can start to get vaccinated? It sounds like the Utah Department of Health is the best space. I also saw that they have a newsletter on their website that you can sign up for vaccine updates. I can put the link into the Facebook Live afterwards, but that might be a good source for people to look at. But anything additional that that we're doing for the 75 and older population once it gets to that?
No, I mean, that came out of CDC, ACIP recommendations in terms of initially vaccinating those above age 75. And then once that phase has started and been initiated, then we'll start the next phase of above 65 or those with comorbid conditions that put them at risk. That's a really, really important age group, are all of those, but that's a lot of people. And so that's really going to start after we really do our frontline healthcare workers, our teachers and school staff, our long-term care residents, our protective services. All of those people are in this first phase in Utah. And then that second phase of, people over 75, comorbid conditions, et cetera, that's going to occur starting late February. And that's just all from reports from the Utah Department of Health.
Someone else asked a question. If someone is vaccinated and the virus does enter their system, hypothetically, can they still spread COVID to someone who is not vaccinated?
Incredible, very timely question. And so what I think the person is asking is, after I've been vaccinated, can I become asymptomatically infected and transmit the virus? And the answer is we don't know. When you look at the studies that Pfizer did and Moderna did, their primary endpoint was symptomatic COVID-19. So the people had to have symptoms of COVID. Then they went and got tested to see if they had the disease. Their primary endpoint wasn't asymptomatic viral infection. And so we really don't know. That work is ongoing in both Pfizer and Moderna studies. In the Moderna data, they did have one look at this. And so in a small group of patients, when they came in for their second dose of vaccine, they did viral swabs for those asymptomatic people getting their second shot, and did show that in the people that got vaccinated with the actual vaccine, they had a lower likelihood of asymptomatic viral infection. Small numbers early in the course of vaccine, we don't know what to make of it. So I think at this point, you have to assume that asymptomatic infection is possible after vaccination. And that is one of the reasons why we still tell people that if you've been vaccinated, you still have to wear a mask, you still have to do social distancing. Those things still apply to you, because it is possible that you could transmit the infection. And you can imagine how you could get lulled into this false sense of security where you say, oh, I'm vaccinated, I'm going to go visit my elderly mother or father, and then potentially inadvertently, spread the infection to them. And so it is possible. We just don't have the data on it yet.
Someone asked a similar question to kind of what you just answered. If everyone in their family or group of friends has been vaccinated after their second dose, can they hang out without masks on and without worrying about social distancing? It seems like you answered that, but do you want to just expand on that?
I mean, I think so much more will be coming out in terms of this asymptomatic infection kind of business. And I think where this is going to be headed is, we have had a huge focus on public health. And then as we move into another phase where we're getting more and more and more people vaccinated, we're going to be moving into more of an individual health kind of risk factor profile and whether or not you got vaccinated or not. And so, you could imagine if you had a group of people that were all vaccinated and are low risk. Keep in mind, vaccine isn't 100% effective in the studies, but if you take a people and they were all vaccinated, that would be a safe population to hang out with, as long as those people then aren't going and hanging out with their elderly parents or grandparents. And so, you have to kind of think in mind, what's that next step in terms of those people hanging out together? And they may be safe, but they may get the infection from somebody in that group. They may not develop symptoms, but they could potentially transmit it to somebody at high risk as they move out of that bubble. And so, we really have to find out what the impact of the vaccine is on asymptomatic infection to be able to answer some of those questions more efficiently.
We touched on this before, but someone wanted to know around the vaccine and pregnancy. The specific question was, is this vaccine that pregnant women should do while they're pregnant or wait until after birth? So that's a little bit different than what we've normally been asked.
Yeah, so the studies, neither Pfizer or Moderna allowed women that were pregnant to be part of the study. And that's pretty standard for phase 3 trials, that they don't include pregnant women. There were a small number of women in the studies that found out they were pregnant after the first dose of the vaccine or after their second dose of vaccine. And so, I mean, those numbers are small, in the order of, I think, 12 patients in the Pfizer group or in the Pfizer study that got active vaccine. And I think the numbers were even smaller in Moderna. So we don't have any good data on it. ACOG, the American College of Obstetrics and Gynecology, came out and said they were supportive of their of pregnant women getting the vaccine, and that they should talk to their OBGYN to see if it's right for you in terms of weighing risk versus benefit for that. And so right now, pregnancy or lactation isn't a contraindication to getting the vaccine. We'll certainly vaccinate pregnant women. Whether or not there's a benefit, while you're pregnant versus after pregnancy, we just don't know. The data hopefully will be coming soon in terms of trials looking at vaccination in pregnant women. This vaccine is safe, we feel, in pregnancy. It is not a live virus, and so there's no chance of this, getting infected with the virus and transferring it across the placenta. And so for those people that are pregnant, planning to get pregnant, or lactating, I would say talk to your OB, talk to your primary care doc, and know that ACOG does support the use of this vaccine in pregnancy.
We also had a question about your thoughts on this how to fight COVID at home that people have been talking about, which is, I'm verbatim reading what it says: laying on your stomach, eating 1 to 2 eggs, bananas, avocado, drinking electrolytes, and taking baby aspirin. Is there any sort of data that suggests any of these things are good at-home remedies potentially for COVID?
First, I'm hearing about it in terms of like treating your COVID, or in terms of preventing COVID?
Not positive. It says how to fight COVID at home. So treating. The answer is,
Okay.
or question was treating.
I would say no. I would say eat a healthy, balanced diet. Fruits and vegetables are always great, but there hasn't been anything to suggest that certain diet is beneficial in terms of fighting COVID. There's some very early data on vitamin D and in terms of having less severe COVID. So, that's more of a prevention issue. I think this line on the stomach bit gets to the fact that in people with severe COVID-19 that are in the ICU, that are requiring high oxygen, we actually do have them lay on their stomach, because we find that you can oxygenate them better and more efficiently while they're prone, meaning on their stomach. But if you're getting to that point where you're needing to do that at home, you should probably be seen in the emergency department or be in the hospital. That's not something that you'll need to be doing at home if you're well enough to be home.
Last question for you. What can someone do to show their appreciation for healthcare workers? This was actually posted on Twitter by someone in response to a healthcare professional getting the vaccine. But what are your thoughts on this?
Yeah, my thoughts are, I think we talked about this last time, is abide by the public health recommendations that we're given. Your biggest gift to us is to not get COVID and not transmit COVID to anybody else. That is the gift you can give us, is, wear a mask, do your social distancing, minimize your contacts, so you're not contributing to the ongoing transmission of this viral infection. And when it's your time, get vaccinated. Those are the things you can do to help all healthcare workers that are on the front lines of this, that are seeing this day in and day out, is don't become a patient. That is our absolute number one request. And if you can do that, we would be forever grateful.
That's a great piece of advice. Continue wearing your mask, social distancing. I think that will definitely help. If you guys have any questions around COVID-19 and want to see if you qualify for a test, you can go to intermountain.com/COVID testing. You'll fill out a really quick form that qualifies you for the test, and then you'll be able to schedule an appointment arrival time. We also still have our emotional relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Dr. Stenehjem, as always, thank you for joining us, and we'll talk to you in 2021.
Thanks, Amanda.
Thanks. Bye.